Good morning. I'm Brett McReynolds, the Vice President of Policy at the American Autoimmune Related Diseases Association and Executive Director of Let My Doctors Decide, a campaign by AARDA that brings together patient and provider groups listed here on the slide in front of you with one simple goal: to ensure that treatment decisions should always be made by patients and their trusted healthcare professional. I'm really looking forward to today's unique panel discussion that focuses on policies and principles that ensure patients and clinicians are making these vital medical decisions at all times, not a third party. We have a great lineup and discussion for you today. Let's get started. It's my honor to introduce you to our moderator, Lilly Stairs, founder and principal at Patient Authentic and vice chair of board of directors here at the American Autoimmune Related Diseases Association. Lilly, I'll turn it over to you.
Thanks so much, Brett, and good morning, everyone. Thank you all for joining us today, and a special thanks to the American Autoimmune Related Diseases Association and Let My Doctors Decide for hosting this unique discussion about barriers to improved health and wellness during the COVID-19 era. After the past 18 months, debates over healthcare and healthcare policy have taken center stage, particularly as we continue to experience the daily challenges posed by the pandemic. While the discussion is often confusing and complex, the overarching solution is not. In short, we must always allow patients and practitioners to make decisions about the best course for their care. I'm a patient and longtime advocate for patients' rights. Several of us involved in this discussion and countless others have been advocating for meaningful policy and regulatory changes to level the playing field for patients, preserve the trusted relationships with our providers, and put us in the driver's seat. As many of us know, our rights as patients and providers are at risk, and with that risk comes detrimental ramifications to our health and wellness. I speak from personal experience as someone living with 3 autoimmune diseases. Over the past 10 years in my time as an advocate, I've watched countless patients that I've worked with, hundreds of patients, deal with the barriers that have kept them from getting the medications that they need and getting them covered in a timely and on an affordable basis. Today's discussion is unique, personal, and a journey through the day in the life of a doctor, patient, and practitioner in the front office. You'll hear about how they've been impacted by harmful practices that make it difficult for us to access medicines and treatments in a timely fashion and as recommended by healthcare professionals. We'll share our personal struggles that stem from harmful and unnecessary business practices, including step therapy, limiting cost assistance programs, non-medical switching, rebate walls, and other harmful approaches that delay health and wellness. There is a silver lining to all of this. It's that patients and providers are taking action more so than in the past. And in many ways, the pandemic has brought us closer together and closer to these conversations about healthcare than ever before. We all have friends, relatives, colleagues, and neighbors who have been impacted in one way or another. Stated simply, the conversation about access and affordability is both important and personal. We need to make sure we get it right. Now, I'd like to take a moment to introduce our distinguished group of panelists. First, we have Dr. Madeline Feldman. She is a leading rheumatologist and president of the Coalition of State Rheumatology Organizations. ANDREA ZLATKUS is the executive director of the National Organization of Rheumatology Management. Tina ASWANI OMPRAKASH is a patient advocate and founder of Own Your Crohn's. And Antonio Chacha is Chief Executive Officer of 46 Brooklyn Research. Thank you all so much for taking time out of your very busy schedules to join us this morning for this important discussion. So let's jump right in and get started. I'd love to begin with you, Dr. Feldman, and hear more about the provider perspective on the challenges to the patient-provider relationship from harmful access restrictions and PBMs. So how are insurers and PBMs making it difficult for your patients to access medication?
Thank you, Lily, and thank you to AARDA and Let My Doctor Decide for having me on today. This is one of my favorite topics, as you know. So people talk about access and affordability. I define access as availability and affordability. And both the availability, obviously, it has to be discovered, it has to be approved by the FDA, and then, of course, it has to be launched. And then, of course, affordability, is it cash price? Is it covered by insurance? Is it just a copay? Is it co-insurance? So there's lots of areas where obstacles can be thrown in. But if we start with just, is it on the formulary? Because we're mainly talking about expensive drugs here. And if they're not on the formulary, patients can't afford them. So who has the power to determine the formulary, the list of drugs that insurance covers? Well, it's pharmacy benefit managers. And, is it always the most efficacious and safest drug that's on the formulary? No, oftentimes it's a higher price drug because we know that formularies are based on the highest rebate, and that can be based on the list price. That takes us into the affordability column. So if a patient has a co-insurance and the list price of a drug is $10,000 a month, they absolutely can't afford it. One of the curious things is we have a drug pricing crisis in the United States, but I'm going to give you an example of a kind of a drug, a mechanism of action of a certain drug used to treat rheumatoid arthritis. It's called a Janus kinase inhibitor. And we have 3 that have been launched in the US. One costs about $30,000 a year, one about $60,000 or $65,000, and one about $70,000. Guess which one can't get on the formulary and is on no Part D formulary, by the way? The one that costs the least. So there, right there is an affordability problem for my patient and for the government if you look at how long it takes the patient to get through the donut hole. The next issue is step therapy. Those are one of the utilization manuals to control the availability. Here we go again, availability to my patients. Step therapy determines the order that my patients can take their medications in. The other types of prior authorizations, I can give you some examples on that, and non-medical switching. So all along the way, has to be on the formulary, has to be preferred for my patient to get it. The affordability is determined by the PBM. By choosing higher priced drugs, that makes them unaffordable. And, all of that together interferes with the doctor-patient relationship and my patient's ability to get the right medicine at the right time, at the right price.
Yeah, thanks, Dr. Feldman. That was such a good overview. And I really like the way that you broke down access versus affordability. The formulary comment really stuck with me as somebody who is on a biologic, and I'm on a very specific biologic that works really well for me, and many of the others have not worked well for me. And I live in fear every year when the formulary comes out, is my drug still going to be on there? And what does that mean for me if I can't have access to that drug? It's kept me in remission, deep remission, for 8 years. And I live in fear of what could happen. And so I know that's the case for a lot of people, for patients and providers. So thank you for that. So as we try to put this into perspective, we know that data and numbers and research are so important in framing all of this. And so do you have any evidence that to show that prior authorizations and non-medical switching are really negatively impacting patients?
Yeah, absolutely. A couple of years ago, Zach Wallace up at Mass General did a very nice study looking at the harm. Actually, he went in, what does prior authorizations do to my care of patients? And he looked at over 200 patients that were needing a particular infusion, and about 70% of them required a prior authorization. The other 30% didn't. And he compared delay to getting the access to the medication and also the steroid burden. So it took twice as long for those who had a prior auth, even if they were initially approved, to get to the medication they needed. And they required 5 times more prednisone steroids than the patients that didn't require a prior auth. And we're talking about patients whose prior auths were eventually over 90% were approved. So here we have a utilization management tool that is essentially useless, delays care, and actually costs the patient, let's just say, affordability in terms of their physical health. Needing 5 times as much prednisone is definitely a harm to a patient. So we see right here that prior auth hurts the patient in the pocketbook and hurts their health as well. And non-medical switching, actually, there's nice data looking at basically changes in the formulary. Sometimes the step therapy changes. It changes if you change jobs. Sometimes in the middle of the year, the pharmacy benefit manager decides to drop. Well, a couple years ago, Maine passed a reporting law looking at any changes to formulary and what did that do to patients. So the first quarter, when they looked at it, over 300 formulary changes happened in the first quarter in those insurance companies and PBMs that they were able to look at. And of those patients that had changes like that, 80% had increased out-of-pocket costs. You know, the patients could always appeal it, but over 50% of the time it was denied. So again, we're looking at the patient losing in terms of their health and also in terms of the pocketbook. So these are availability and affordability obstacles that are put in place by the pharmacy benefit managers that interfere with the doctor-patient relationship, interfere with the patient's health, and cost them more money.
Thank you, Dr. Feldman. Again, beautifully said. So it really is having some of these new age innovative medications that are safe and are really helping autoimmune disease patients is a miracle. And it's scary and sad and frustrating that so many patients struggle to access them. So thank you, Dr. Feldman, for that wonderful overview. We really appreciate you being here, and we will be circling back to you in a little bit to chat some more. So now I want to turn it over to Andrea, who is on the front lines. You and thousands of your colleagues are front office warriors, spending so many hours with patients, on the phone with insurance companies and payers, and taking time away from actually working with patients. So I'd love to have you describe some of the barriers that insurers and PBMs are putting in place that office staff and patients have to navigate before patients can actually get to the medicines and treatments prescribed by their providers.
Thank you, Lily, and thank you for giving me this opportunity, because, it's always been my mantra at the office that once the doctor and the patient makes a decision on treatment, we want to see that happen. And the barriers are there. We feel like we're jumping through hoops trying to make that happen. And as Dr. Feldman has said, she's addressing a lot of these barriers with non-medical switching, step therapy. But I want to spend some time what my staff does is the prior authorization process and trying to make this happen. So for an example, my staff spends approximately 60 to 75 hours out of a 400-day work week. We're a small practice. That's the hours we spend trying to get through the prior authorization process, the benefit investigation, and the appeals process, and trying to get our patients on formulary drug and the drug of choice from the physician. Dr. Feldman mentioned having drugs that are not on formulary. I was in the office yesterday and my staff came up to me and said, we're trying to get this patient who has psoriatic arthritis on therapy, and it was denied. And she showed me the list of drugs that they suggested that could be used for this disease. One was not FDA approved. So here we are having FDA approved treatment. That's denied. And then they give us an option of one that is not even FDA approved. And the other two were actually, my physician said they're not even standard of care. He wouldn't even consider using them for his patient that has psoriatic arthritis. So these are, just some of the things that we go through. There is a process in place, as you mentioned, that we can go peer-to-peer. We can try to appeal these decisions. That too takes a lot of time from our staff, but more so from my physician who should be taking care of the patients. So most of the time when you go peer-to-peer, it takes a while to get that scheduled. They deny the request from the get-go. So my physician spent the time, went peer-to-peer, and the doctor said, well, the diagnosis isn't on my list and I can't deviate from my list. And he's like, what's the purpose of going peer-to-peer if you can't change it? And they said, well, you can appeal my decision, which we did. Eventually, it did get approved. But the time frame from the time that decision treatment was made to the time that we actually got it paid or approved was 45 days. That's a month and a half, more than a month and a half of getting our patients, again, to your point, they were put on steroids to control their disease. And this was not, what we wanted for our patient. So this is the things that we go day to day through. Of those hours, like I would say my staff says the main pain points for them when they're trying to do that prior authorization process is miscommunication, contradictory information between the pharmacy, between the PBMs, between the insurance companies. We're told various things. Yes, you need a prior auth. No, you don't need a prior auth. So we don't get the prior auth. The claim is denied because we didn't have a prior auth. And we're constantly fighting these battles. The actual prior auth process can be very complicated. They have one form for a patient. It's an Aetna where they actually have 15 pages to fill out to complete the whole prior authorization process. So understanding the difference between the medical benefit and the pharmacy benefit, as Dr. Feldman had mentioned, many times they're switched from the medical side of the business to the pharmacy side of the business. And then they're put into a situation where they have the cost accumulator plans, which then turns more of the cost to the patient, right? So that's something I know that's going to be addressed as well. Patients are confused. They're getting letters from the insurance company saying their information is denied, their treatment's denied. They're calling us. In the meantime, we're still fighting that prior authorization and the appeal process. And we're trying to say, hang on, we're working on for your behalf, and we will get this done. There is not only do we find these battles before a drug is actually approved, in a situation where they say you do not need a prior authorization, and we go ahead and administer the drug, before they pay the claim, they will turn around and do a post audit. So they actually look for the medical records. Now they want us to prove that we actually gave the right treatment for the right diagnosis to the right patient. And we're like on hold. Now they have to review these records. We don't want to give the patient additional treatments if it's not going to be covered. And so again, the patient's the one who suffers because now they have a delay in treatment. So these are the things that we battle on a daily basis with the prior authorization part of it. Even an HS and OIG study in 2019 showed that Medicare Part D beneficiaries, they had avoidable extra steps that can delay or prevent access to prescribed drugs. And the study also showed that the coverage denials were appealed. 73% were then approved. But when you're talking about the Medicare population, my mother just turned 88. When she hears from the pharmacy that her drug has been denied, she's like paralyzed. And of course she calls me, right? So I'm her 911 call, but she turns around, she goes, I don't know what to do. Like she panics. So these are what our Medicare patients face too. It's just not our commercial patients, but it's our Medicare patients as well.
Yeah, thank you, Andrea. And it is harrowing to hear how much time that you spend on the phone and trying to fight this for patients. And not only is it impacting their health, but the patients are also really have a huge administrative burden on them as well in this whole process, because they're all often coordinating with you. And when we think about that, these patients are sick, they are in a state of really not feeling well. When my diseases are active, I have total body arthritis to the point that I can't move. I have bleeding ulcers in my small intestine. I can barely talk. Never mind try to coordinate getting this medication approved that would make me better. It's a broken system. And you are doing God's work in your office.
Anytime that you find that your medication has been denied and you now have a delay in treatment, that adds stress to you. We know stress does not help any of these conditions as well. So, the patients are really suffering.
They are. Absolutely. Stress is the number one trigger for autoimmune conditions. So very recently, there were some headlines about an insurance company that is offering to pay patients to, quote unquote, switch medications for non-medical reasons. Can you tell us how patients at your practice have been impacted by this, and then the potential for harmful outcomes because of it?
Yes. And some are calling this modern day bribery, right? So our patients are getting letters offering them a $500 debit card to switch from the drug that's currently working to another drug that's on formulary. One was in the pharmacy area of subcutaneous injections, And there was one injection that they were taking off formulary. So they were offering them the $500 to switch to like 8 other therapies. Some of them weren't even the same class of drugs. And, the patients are confused, but in the time of COVID, when everyone is stressed with their finances, with everything that's happening with the economy, that $500 debit card sounded really great to them. And they're calling and saying, well, can I switch to this drug? And then if it doesn't work, I'll just switch back. But we all know that it's not easy just to switch back. It doesn't always have the same effect. And you can't just switch from one drug to another. They're not interchangeable. And they don't explain that to the patients. They just offer them the money. And then recently, our patients also got a letter saying that if they would switch from a reference drug to one of 2 biosimilars, that they would also get that $500 rebate card, or not rebate card, it was a debit card. So our patients are calling and saying, well, why are they telling me to switch? And there's 3 biosimilars for this reference drug, only 2. And it's the 2 that the PBMs have, negotiated their rebates and their profitability on, that they're getting those $500 debit cards. So patients are confused. They're like, in some ways, $500 sounds great, and they can use that money. But then they worry about, what does the impact to my health and my treatment? Will I stay controlled? Do I need to move back? And can I move back if that drug is not working? So it's causing a lot of angst for our patients. And I really think that insurance companies should not be able to offer a patient that $500 debit card just to make a switch.
I couldn't agree more. I mean, these are really big life-changing decisions that can drastically impact health. That should really be coming from a shared decision-making between the doctor and the patient. And so I just, one final question for you, Andrea, at this time. Do you have any stats that illustrate the unnecessary costs associated with some of the wasted time for office managers and the impact to the patient's bottom line and the negative implications on their wellness? That's stats for a lot of different things, but whatever you have.
Norm actually did a study a few years ago to see what it took to put a patient in an infusion chair, right? So, it sounds simple, but when you look at the benefit investigations, the prior authorizations, appeals if they're necessary, everything that we do to get that patient in the chair, that study at that time has showed that it was approximately $77 to get that person in the chair. Now, that's not just a one-time cost, because the next time they come into that chair, you're still checking eligibility. Was there change in formulary? Is the prior authorization still in place? I actually had an insurance company take a patient. We had the prior authorization. It was on the system, and they denied the claim, saying that they retroactively denied our auth. And now we were fighting that claim. It's just everything that it goes through to take that patient. And that practice, we did the survey, was a highly efficient running practice, right? There is constant change in the medical field. New patients, new staff that are coming on that have to learn and be trained how to do this process. So when you look at the areas, if you kind of was looking at some of my board members, and we figured it's probably between $95 to $100 to get that person actually in the chair. And that's a lot of cost to the system. I mentioned that, we spend that 60 to 75 hours just doing the prior authorization. When you look at salaries, it really is close to $65,000 to $78,000 per year spent for my staff to do the prior authorization process. And that is not reimbursed by the insurance company. That's just cost of doing business to get our patients in the chair. And so these barriers just, that are unnecessary, as Dr. Feldman mentioned, most of these are overturned on appeal, that they do eventually get approved. That's a lot of waste, both from the insurance company perspective, from our patient's perspective, and from the practice perspective, and cost that has, just gone down the drain.
Oh, absolutely. Well, thank you, Andrea, for that holistic picture of what you're experiencing and how that's impacting patients. I really do think that you you are totally front office warriors who are there for the patients. And I'll also say that I'll add that there are a lot of practices that maybe don't have front office warriors like yourselves, right? They don't have the funds. They don't have the ability to have staff who can support patients and help fight to get them on the drugs that they need. And so there are a lot of patients who are just going fully without it, right? So that's a big piece too.
There's a lot of burnout. There's burnout with the physicians. There's burnout with the patients. There's burnout with our staff in fighting these. And I will say, and you had brought this up, one of my coworkers, she has RA. And this year she was not controlled. And, we talked about the stress and everything that she fights every day to get patients on drug. We were having a challenge getting her on therapy. And to see her coming in late and barely able to walk, it took her hours just to get out of bed. And then she comes into the office and she can't hold a pen because her hands are so swollen. It just brought like tears to our eyes and actually watching her. And here she's on the phone trying to help other patients to get on therapy.
And it's the stories like that that really stick. And so thank you for sharing that, Andrea. And it's really the perfect transition to our next speaker, the amazing Tina. I have had the opportunity to work with Tina for a number of years now. We are both IBD warriors, and she's one of the most dedicated, brilliant advocates I've had the pleasure of interfacing with. She really gives it her all for the community that she serves. And we're so grateful to you, Tina, for your willingness to take the time today to share your personal experience and illustrate how frustrating and dangerous these barriers can be to the patient community that we serve. So I'd love to jump right in and have you start by telling us about your personal story and experience with getting the treatment that your provider originally prescribed, and that you both decided in a shared decision-making process that that's the therapy they wanted you to be on.
Absolutely. Thank you so much, Lily, for having me here today. Thank you to AARDA. And thank you, Dr. Feldman and Andrea, for your hard work in standing up for us patients. It goes a really long way, and I want to make sure that we appreciate it. Lily, going back to your question, I think this has been really tough. I've had Crohn's for over 15 years now, and every 6 months, the prior authorization process forces me into, hey, we need your medical records. Hey, we need to understand why you still need to be on this medication. And I've been, like you, in deep remission on a particular biologic for over 6 years now. And I've, had over 20 surgeries, live with a permanent ostomy bag because no biologic was working for a long time. I was a patient who experienced step therapy and was delayed in my care into getting onto a biologic because I was forced to try steroids, which you elaborated on, and I was forced to try other forms of immunosuppression that did not work. And I actually landed in surgery in that process 13 years ago and lost my colon. So these delays can have some serious impact on patients' quality of life. And these delays can lead to complications of disease, as Andrea was talking about. For Crohn's disease, that can mean things like fistulas and strictures. What are those? Strictures are a narrowing of the intestine. Fistulas are abnormal tunnels that get created from our intestine into other areas of our body, resulting in a whole body type of infection called sepsis, which can be deadly. So there are serious ramifications here to patients not receiving their medications on time. I wanted to share particularly an anecdote of a recent experience that I had with my insurance company over the last 2 months. So I've been on this biologic, as I've mentioned, and it's been really helping me. The thing is, it's FDA approved for 8-week intervals. And this is something I'm hearing about regularly now from my IBD center and from other patients. Because I'm on an off-label dose of receiving that biologic every 6 weeks, giving myself an injection every 6 weeks, instead of 8 weeks, which is what the FDA has approved it for, I was getting rejection after rejection from my insurance company while my the staff at my IBD center were working diligently to try to get that prior authorization approved. So I was going back and forth with my IBD nurse and with the prior authorization department. And mind you, I'm in New York City, and I go to one of the top facilities for IBD care here. And they were telling me that they're experiencing this left and right, that they have many, many severe IBD patients who are on this medication every 4 weeks or every 6 weeks, and every single one of them is being rejected. So what did we do? We filed state and federal appeals. My doctor had to have a peer-to-peer review. Now, I need to, elaborate a little bit on this, because my understanding from speaking to my doctor and speaking to other doctors is there's a lot of back and forth with these peer-to-peers. So first of all, you don't get another gastroenterologist on the phone. You often get somebody like a PA status or NP, or sometimes even a primary care general practitioner on the phone to hear your concerns around the patient not receiving the medication. So this person might not be specialized in the area of gastroenterology. And then on top of that, they keep rejecting and rejecting and rejecting because they don't understand why the patient needs this medication. What I ended up doing is going into my doctor's office, sitting down with the staff and sitting down with the IBD nurse to share my story and say, look, I've had 20 surgeries. I've had significant fistulizing disease that's already been caused by significant delays to medication and access to medication. If I don't get this medication in a timely manner, I could risk flaring and I could risk ending up in surgery. They were trying to force me back onto an 8-week dose. And I did flare 2 years ago on that dosing. We had to heavily sort of state my previous history in order to finally get approval last week. I took the medication late by about a week, just this past weekend. This should not have to happen. Luckily, I did not need steroids. I was able to do okay with extra rest and just taking care of myself, but this should not be something that patients should have to go through. The stress itself was not allowing me to sleep at night. I was really worried. And I have to add one other point here that's very important. My husband pays $1,200 a month for my health insurance to make sure I have coverage for biologics and that I have coverage for ostomy products, because they're both very expensive. The moment my insurance company comes back and says no to something, it's one of those things like, I am paying so much for this. It's practically a rent for us. And we have to try to save for this every single month. And now you're adding this additional burden of a medication that costs $23,000 every 6 weeks for me, and telling me that I may not get it. How much more surgery can a patient have?
Tina, everything you share, your story is so powerful, and there's so much to unpack here. There's so many points I want to hit on, and we have so little time. But, one thing I want to call out is that it's very clear, and I'm sure everyone on this call can tell that you are a very seasoned advocate, right? You work in this day in and day out. You really understand the policy. You have an MPH. You understand the system. You went through all of this time and struggle to get to this approval. You fought and you fought and you fought. There are a lot of people who don't even come close to having your knowledge and breadth and depth of the system. So, imagine this happening to them. If it was this much of a struggle for you, then it's got to just be almost a non-starter for a lot of people. So that's one piece. The next piece I always like to point out, because when I think about the fact that this is a congressional briefing, and we think about the fact that we all understand here that cost and money is a driving factor in a lot of policy, and it's a driving factor in the decision these insurers are making. What is, for lack of a better term, bananas to me, is that when insurers force patients to go through step therapy or a switch, and they end up in surgery, having 20 surgeries. Yeah. Is that really saving money? I don't think so. When I was in the hospital before I was able to get on a biologic, my 2-week hospital stay was over $200,000. So we need to look at what is the actual cost of a patient. If we're going to remove everything else, if you drill down to cost, bottom line is, I'm not so sure there's actually cost savings happening there. So anyways, just two pieces that I wanted to point out. And I'm so glad that you've been able to fight this fight and to raise your voice for others and, be an advocate in our community. We're very lucky to have you. So thank you so much, Tina, for sharing.
Thank you.
Okay, now, Antonio, last but certainly not least, I'd like to circle back over to you and talk a bit about what's driving these barriers to access by highlighting the role of PBMs in the ecosystem. So you've been leading the charge in the state of Ohio on these very real barriers that patients and providers face on a daily basis. Can you tell us more about what happened in Ohio with PBMs and how other states are learning from Ohio's experience?
Absolutely. It's great to be on this panel because this is a very entertaining topic for myself. Unfortunately, it's a very real topic for the patients and employer have to pay the bills for it. PBMs began as what I believe is a necessary check and balance in the system. At the beginning, when PBM started, drug makers, realistically could bring any drug to market and charge whatever they want for it. They could sell it to wholesalers who could mark up that drug to any degree they want and sell it out in the open market. And they then sell it to pharmacies who, again, for-profit entities, as well intended as they are, also would like to ostensibly charge as much as they would like. And so PBMs and insurers were constructed on the other end of the transaction to make sure that perhaps we weren't paying for drugs that we didn't need to pay for, or perhaps make sure that they weren't paying too much for a drug based on its value proposition, or not overpaying a pharmacy for the needed service that it provides. But at the end of the day, you have one side of the supply chain that would like to charge, and you need something to counterbalance that on the other end. You can't just give the other side a blank check. The problem is that while all of that is great in theory, is that when it actually spills out into the real world, you have a highly complex, convoluted system that is laden with conflicts of interest. Because PBMs don't act as a necessary check on the other end of the supply chain. Over time, they've evolved because PBMs are not PBMs anymore. PBMs are insurance companies. PBMs are rebate aggregators. PBMs are pharmacy companies now. And so while they were meant to essentially control the other side of the transaction, they have become the other side of the transaction. And so with that comes a necessary, I think, breath that we all need to take and say, what is a PBM? Are they actually here to save money, or are they here to print money off the transaction that they were hired to control? Our data research shows that the latter is very much the case, especially in an over-consolidated marketplace that is exceedingly opaque, which presents a ton of opportunities to skim off the top. Dr. Feldman, I think, brought a very fundamental understanding or learning to, I think, this conversation, which is, drug makers, in order to get access to the market, they need to make their way onto PBM formularies. And so then what is a formulary? It is the PBM's curated list of drugs that they choose to cover. Well, the question is, how do they choose to cover those medications? Now, oftentimes they'll tell you that they're making those decisions based upon whether the drug is in the best interest or has best results, or whether or not it's cheaper. Well, the reality is it's not what's cheaper, and it's not necessarily what's more effective for the patient. PBMs are using their ability to restrict access to patients. So take drugs and say, hey, drug makers, your drugs will not go to the patient unless you essentially entice us in a way that is in our interest. So they use their ability to restrict access on a formulary as a means to court favor with other manufacturers who are on the formulary. And the way that they make those decisions are not necessarily purely predicated on, is the drug better, or is the drug of the best value proposition relative to its competitors. They make those decisions based upon whether or not they have the right enticements. And the enticements are generally rebates. And so those rebates are a growing pot of money that have been growing significantly over time, where drug makers at last count are shaving off at least $175 billion off the list prices of medications and then flowing them back through the drug channel. PBMs can relabel those rebates however they want. They tell people often that they pass 99% or 100% of the rebates back through to plan sponsors and patients. But the reality is they're just redefining drug maker compensation in a number of ways and saying the rebate is something and then fees and everything else are something else. So the truth is that formulary exclusions have never been higher than they are today. The big three PBMs are excluding more medications from their coverage list than ever before. And so Andrea made a really good point that I want to go back to. She talked about how, look, I think prior authorization is a double-edged sword. You ultimately want to make sure that a patient is getting a medication they need. You don't want a health plan overpaying or paying for medications that aren't necessary, but there's a balance to everything, right? A 15-page prior authorization in order to cover a medication, that's not intended to make sure that the drug is right and appropriate. That's a barrier. That is an intentional hurdle that they are putting on a physician in order to get a patient the medication they need. So the question then is, why 15 pages? Okay, well, the reason is because drug makers know that 15 pages is a huge disincentive for the physician to prescribe that medication in the first place. And what they do is they go to a drug maker and say, hey, if you don't want that 15-page prior authorization on your drug, well, we're willing to get rid of it for a price. All right. And that price is the rebate. And so there are drugs where you don't have to go through the prior authorization process. There are drugs that are at the beginning of the step therapy where you don't have those types of barriers. And PBMs are selling the ease of access in the form of getting larger kickbacks from those drug makers. Drug makers, in turn, respond to having to pay those taxes to the PBMs, and I say taxes in a general sense, by raising their list prices to make for more concessions and enticements to the PBMs to cover the drugs in the first place. I say all that not to just go down this rabbit hole of rebates, but as a fundamental learning that PBMs use their ability to restrict access to certain providers and restrict access to certain medications as a means to create financial enticements for themselves. Now, that learning is true across the spectrum of PBM compensation. In Ohio, where we got our start, PBMs were taking advantage of their role in the middle to essentially hide money from state officials in our state Medicaid program to underpay pharmacy providers and then upcharge on those same transactions and then packet the spread over top of that. Well, when the data analytics that we did in coordination with local journalists helped lead to a crumb trail where our state auditor decided they were going to open the books. And when they opened the books, they found that PBMs were skimming $244 million per year in just 1 year of our Medicaid managed care program, where they were paying pharmacies low, billing the state high, and pocketing the difference. Now, just to give you a sense, I'm sure folks at the federal level have heard about the spread pricing controversy, but it is only just now coming to a head. Our state attorney general in Ohio sued PBMs over these practices. And just last month, for the first time ever, the state attorney general has reached a settlement with a PBM. This is the first and largest settlement of its kind, where Centene, a managed care plan that owned their own PBMs, settled for $88 million in paybacks to the state of Ohio, $55 million in Mississippi. And they set aside an additional $1.1 billion to settle projected settlements in other states across the country. Now, again, this is not just a them problem. This is an epidemic across the continuum of the PBM marketplace. I say all this because this is fresh, all right? This was just learned last month in terms of the settlement, but there's a lot more ways that PBMs can evolve and take money off the transaction. So just when you think you have the answers, they change the questions and recognize that PBMs are not required to be fiduciaries, meaning they are not required to act in the best interest of patients or their plan sponsors. So my counsel to folks that are seeking to get a hold of this, especially to my colleagues in the state of Ohio who have really been at the tip of the spear on this, is that PBMs aren't PBMs anymore. And so to the degree with which we can sterilize and eliminate conflicts of interest and inject necessary transparency into the drug supply chain, the better off we all are and the least we'll pay at the end of the bill.
Antonio, I think that's one of the most thorough explanations I've heard of what this landscape looks like. So thank you so much for sharing that and helping put context around some of these different experiences that we've been hearing today. I want to pause for a moment to remind our audience to please jump in and ask some questions in the Q&A, as we will have some time as we near the end here to answer any audience questions. And now I want to open it back up to the group, and I'd like to start where we began with Dr. Feldman. And I'd love to hear from you, Dr. Feldman. What can we do? What can we do to take action on these access and affordability issues that patients are facing?
Well, a couple of things I just sort of want to comment on, as I now did not have the opportunity to hear everyone speak before I spoke, and everyone has made such great points. And one of the things that I think Antonio brought up that becomes clearer and clearer, particularly when it comes to the discussion about competition. The last administration and the present administration keeps talking about we need more competition to bring down the price of drugs. However, if you really look at it, the highest list price can offer the best rebate. So consequently, competition, it actually is increasing the list price of the drugs. So it's not competition, the competition to get on the formulary. So we need to kind of rethink. It's interesting, there was a recent legal case involving racketeering and bribing, and yet the PBMs have safe harbor from the anti-kickback statute. So somehow they have safe harbor, but we don't want the pharmaceutical manufacturers to actually kick back to them. The entire system, and so I guess this is really a roundabout way of answering your question, in order to actually bring sense and lower prices to the system, it really needs to be disruptive. And one of the first ways is to actually take all that middleman money and apply it at the pharmacy so the patients get the benefit of that rebate. But I can tell you, there's already been a lawsuit on the last rebate rule by PCMA. There's been delays in that. It's going to be very difficult. But if we really want to see the true competition, let them compete on price. Manufacturers don't want to do that because they're afraid then their prices will come down. The PBMs don't want that because then their rebates are going to go away. So we have two very, strong and powerful forces that are making the real answer to this question almost impossible. I mean, I don't know. What do you think, Antonio?
Yeah, you're spot on, Dr. Feldman. This is timely right now because I'm just reading, over the last day or two that the Senate is looking at taking the rebate rule and exchanging it or kicking the can as a means to provide savings, for the infrastructure package. And so Dr. Feldman's spot on. The Senate Finance Committee already answered this question for us with their insulin pricing investigation. Insulin is a very competitive class. You have a massive disconnect between the list price and the post-rebate price. And so it's a perfect example of how competition is actually driving prices up. And so when politicians and media clamor about, look, we need to do something about high drug prices, if you divorce rebates and rebate reform from that conversation, then you don't actually care about high drug prices. It's theater at that point. Competition is driving prices up. And so until you change that fundamental dynamic in that broken incentive system, you will continue to have this problem where prices are going up in a significantly higher pace than is, I think, sustainable to the overall system, especially when the middlemen are able to skim off the top of those rebates in the first place.
2 years ago, when I testified before the Health Subcommittee for Energy and Commerce, the representative from PCMA, based on what I said, Anna Eshoo actually forced her to say, we put higher priced drugs because they cost less. I mean, that's like, what's the definition of is? Because they cost less to whom? So it is a complex system, but we can't decide not to deal with it because it's complex.
What a fascinating discussion. Thank you, Dr. Feldman and Antonio. I'd like to now ask Tina a question. What do you think patients need to know? And what's most helpful for patients to move forward in navigating this and raising their voices to fight it?
I think that the issue is insurance feels like almost like a degree that you need to get as a chronically ill patient. To be honest with you, Lily, something that I've had to do over the years is really read up on every single policy before I buy into it. And that even includes when my husband changes jobs, making sure that every medication that I'm on, and I'm on a lot of medications, is covered or is somewhat affordable. And I will drive HR insane in the process trying to do that. But going back and forth with my providers to see if they take that insurance, it's a lot of legwork to change insurance policies and to really understand the terms like copay, deductible, coinsurance, out-of-pocket max, and in-network versus out-of-network. I think these are all terms that patients have to become familiar with over time, because for a lot of us, there's no one sort of advocating for us besides ourselves. And a lot of times, if it's pediatric patients, there's no one besides parents to advocate. So there's a steep learning curve here. And it almost feels like, as chronically ill patients, when it comes to health insurance, that is, it's hard enough to gain acceptance over the condition that you might be suffering with. And now you've been hit with this hurdle of, how do I navigate health insurance? How do I navigate access to these medications? And going back and forth with your provider is only going to teach you so much. You have to really take that effort on your own to understand these terms and to research them. And I think that's where the self-starter aspect comes in for a lot of patients. And it's very, very difficult, because a lot of us, like you said, Lily, are have full body arthritis when our Crohn's flares up, or, can't move or can barely speak, when our intestines are bleeding. We're too busy trying to figure out how to, not go to the bathroom 40 times a day, let alone forget about trying to understand insurance. It's just completely over our heads. So there's a lot here that I think can be done in terms of interventions to understand health insurance, especially for newly diagnosed patients, whether that's guidebooks or training sessions. I really think that something more needs to be done by, and it wouldn't necessarily be the responsibility of the doctor's office in terms of training patients to understand what insurance is like. Something has to come, I think, from patient advocacy groups that really helps us to understand, how does insurance work? How do we advocate for ourselves in the insurance process? Because like you said, Lily, it's very, very challenging. For me, I've had to learn a lot of this, and I'm very persistent because I want the best quality of life for myself. But it's very easy for us to fall into depression and not want to also, for a lot of us, we're just so fatigued to even try to learn about these things. And it's very, very depressing. And a lot of us end up in medical debt. I really think that more needs to be done coming out of various patient advocacy groups to help us navigate and understand insurance better and understand our rights better. And I think there has been more of a push towards that recently. So in addition to sort of legislative events and speaking to Congress or Senate, I think it's going to be imperative for a lot of us to understand the terminology, especially with sort of the Affordable Care Act. There's so many different policies. How do we even make sense of those policies on the exchange? So I really think there needs to be more done on that front to help patients and their caregivers navigate the system and understand what happens with the prior authorization process and understand what happens when things get denied. Because for a lot of us, it feels like the end of the world when we get that denial, because some people may not know about the appeals process, and some people might not know that they can complain to an insurance commissioner, So there's a lot of patient rights that we don't know about. And I think more education on that really needs to come forward.
Absolutely. Thank you, Tina. And now we just have a couple minutes left here. So I'd like to ask each panelist in 30 seconds, what do decision makers in Washington and across healthcare need to know about the urgency of helping patients at the pharmacy counter? And Andrea, I'll start with you.
Thank you, Lily. I think what they need to know is the true struggles that these patients face on a day-to-day basis. And we need to educate not only the patients, but the people in their HR departments that are making these decisions. They're being sold products that at the end of the day do not help their employees. And so I think they need education as well.
Thanks, Andrea. Antonio?
The fox is guarding the hen house. How much longer do you want to allow that to continue? The conflicts of interest that exist within the current insurance and PBM model are not just disenfranchising patients and overcharging them, it's impacting small employers as well. And so we cannot continue to allow the status quo to continue. And you have to work to reduce, if not eliminate entirely, the conflicts of interest that keep them from being what they're supposed to be, which is creating access to and efficiencies within the drug supply chain.
Thanks, Antonio. Dr. Feldman?
I just echo Antonio's suggestion, and remember that everyone in the drug supply chain, for the most part, all of the middlemen, including manufacturers, everyone makes more money when the price is higher. So if we really want to call it a drug pricing crisis, that needs to be addressed. And dancing around it and worrying about premiums going up, all of those kind of things are all just part of the profit center. And I will tell you, there was a question is why aren't PBMs responsible, and why aren't they responsible for all of these decisions they make? They turn around to us, the doctors, and say, doctor, you can prescribe whatever we want, whatever you want. We're not responsible for that decision. We just won't pay for it.
Thank you, Dr. Feldman. And ending, as we always should, with the patient voice. Tina, take it away.
Absolutely. I think I would want especially legislators to understand that many of these conditions are progressive and wear us down over time, and that time is absolutely of the essence in our care. And just to close off, I have to say one last thing, and that is healthcare is a human right. Price gouging is not something that many patients can afford to deal with, especially when we have such progressive illnesses.
Thank you, Tina. And thank you all so much for joining us. I'm going to pass it back over to Brett to close us out.
Thank you so much, Lily. And thank you to all of our panelists today. What powerful stories and what great advocates. It's hard to sum this up, but if I might, I would say, patients are being denied access to life-saving medicines, even when their doctors and clinicians prescribe them. This has to change. The stories here are only a small percentage of what I hear and we hear day in and day out. So I'd encourage you, learn more about the barriers and this access to care and these issues and the important work being done at Let My Doctors Decide from patients and providers at letmydoctorsdecide.org. Thank you so much for joining us. Have a great day.